morning, everybody, and it really is a privilege to be here this morning to talk with you briefly. I'd just like to start off really by thanking the GPs, the GP practices, Connor, his team, InvestNet for organising such a fantastic conference. And I suppose the group we have today are probably all the converted, but we do need to spread the message. I suppose my own background, I've been fortunate to be working, and I work pretty much half the time in Ireland, half the time in the UK, so almost certainly on a weekly basis, I'm actually being exposed to two different health systems, so it's been a very interesting comparator for us over the last number of years. Sorry, slides, guys. I'm going to keep going. So what I'm going to talk to you today about, I'm going to briefly talk about the case for primary care. Don't need to say much on that. But I then want to talk about some delivery solutions, how we might be able to make primary care happen. And I want to talk, I suppose, at a micro level. I'm going to leave all the policy decisions to the Minister and some of the other clinicians who are working actively on this. But I do hope to spur some thought and give some practical examples of where we've been undertaking work and have seen very substantive improvements within primary care. And I'd like to share some of those with you, because again, the title, of course, of this particular session is about kind of scarce resources and getting more from less. So I'm not going to say much about this other than to say, I suppose we spent the last 9 years working on both sides of the water, being 100+ practices. We're very fortunate to have won a contract in London to look at 38 practices very recently, and this is looking at practices and preparing them for the Care Quality Commission standards. So I'm going to share those experiences with you. We're also a strategic partner with the NHS Alliance in the UK. So look, you all know that change is happening. The reason I put this slide up is that it's going to affect everybody, and everybody needs to prepare for it. I'm involved in a lot of change management, and one of the biggest things you need to do is obviously get everybody around the table involved, inputting, talking, sharing their views, sharing their concerns and addressing it. And often the biggest thing is to get everybody into what I call the unfreeze mode. So it affects everybody, and all the changes that are happening in the healthcare system are going to affect everybody here in the room in one form or another. Just like you to relax for a little minute, close your eyes if you want. Don't go to sleep, because that's not a good sign. Or although I'm reminded of a lesson my teacher taught me. He says, it's okay if you nod off and doze a little bit, that's okay. But when you start doing this and putting your watch to the ear, then that's an indication I really need to move on. But imagine if every patient who really needed a bed in a hospital had a bed available. Getting a bit sleepy? Imagine if many more people could be effectively treated for chronic diseases in their local communities, or as Minister Riley said, in their homes first, or in their local communities, or in a primary care like this. And imagine if these two events were connected, cost less, and delivered better outcomes. Then we'd see the implementation of what Minister Riley was talking about this morning. Then we'd see the delivery of over 95% of the healthcare within a primary care environment, within a community or within a home environment. The case for primary care is actually well highlighted if people would like to see a summary on this website, which is the Association of Irish Primary Care. But this is what we're all striving for. Chronic disease management, again, I don't need to say much on that, other than to say, 80% of it accounts for 80% of all healthcare costs. And a lot of this work could actually be done in the community. And chronic disease management is the foundation of most effective healthcare systems in the world, and is, I suppose, central to some of the primary care strategies that are being discussed, but we'd like to see it actually happening. So next, quality and TQM, what is this all about? Well, we're talking about trying to get more for less, and now I'm coming down to a micro vision of things. Passionate believer in total quality management, which is all about relentlessly pursuing waste. And I have to define what I consider waste. Waste is anything in the process that you're involved in that you don't need to do, or actually doesn't add value. So take the case of the patient coming to see their GP, for example. Any block on that process is waste and should be eliminated. Now, there is obviously a need, regulatory needs and whatever other needs, but very often we just put more and more waste into the system. And what TQM does is looks at eliminating these challenges the barriers, challenges work habits, And I spoke at a conference recently, and I made the claim, and I'll make the claim here. If you spend 4 hours working and just timed it all, say tomorrow or sometime during the week, I would be very surprised if there wasn't at least 50% of that you, if you really challenge yourself, that you could turn around and say, listen, I shouldn't be doing that because it's adding absolutely no value whatsoever to what I'm doing. And that might even be generous. I do this myself all the time, and sometimes it's frightening. So the philosophy is relentlessly eliminating waste. It's benchmarking and sharing best practice. And now flipping over to the UK, we, again, I think have been very fortunate to work with Mike and his practice. It's a 15,000 patient practice. Mike was a little bit modest in some of the work that they're doing in the Northeast, which is all about introducing what are called lean techniques into their healthcare system. Mike has been doing it at a macro level. We're doing it actually at a micro level. So then talking about service delivery, you know, how do you remunerate the clinicians for getting involved in these programs? And this is just a very simple model that I'd like to outline. Life isn't quite as simple as I always make it out to be, but still, let's not make it complicated. On the commissioning side, this is the process by which the health needs of the local populations are identified, priorities for investment are set, and appropriate services are purchased and evaluated. So you have your commissioning groups that will be made up of clinicians, managers, etc., and they will look at the health needs for a particular population. Then they will actually go out and actually any willing provider can actually bid, in effect, to provide that service. So a healthcare provider is a legal entity or subset of a legal entity which may provide the healthcare under NHS service agreements. So your GP practice, your NHS trust, your independent provider, they're all provider organisations. So you have this clear divide between commissioning and provision of services, and then in between all of this you have competition, which is supposed to drive efficiency and value money. The reason I put a question mark after that is that that's obviously a very debatable entity. And then around competition, in order to control standards, you have regulation, standards and quality. This is just a slide on the Care Quality Commission. I'm not going to talk much about it, but it's the introduction of the standards which go behind, I suppose, the regulation in the UK. You know, I would imagine in time similar standards will come down the tracks here. But the interesting thing about this, and I'm not going to go through them all, but there are 16 outcomes, but they all focus on outcomes. So, for example, personalised care, treatment and support there. The first one is about the care and welfare of the people who use the services. And when we go in and look at practices, we're actually challenging clinicians to demonstrate to us. So we're lay people going in, challenging what the clinicians are doing to say, well, how can you demonstrate the evidence that you are actually involving them? So it's quite a different thing to just having policies up on a shelf that nobody actually adheres to. This, I don't have time to talk about this. I'm just giving you the result. There's only one figure you need to see on this, if I can get this thing to work. But this was a study we did on access using TQM at the large practice in the Northeast. We put together a multifunctional team which consisted of clinicians and managers. There was a major problem with the whole appointment system, and patients couldn't see, etc., etc. The most obvious solution was to hire another doctor, another nurse, and basically the practice couldn't afford that. We got it externally measured, and our benchmark was 8.17. That's 8.17 patient average visits per patient per year, when we were told the national norm was closer to 5.5 or 5.7 weighted. So using TQM methodologies, and again, I don't have time to describe the whole process, but we worked on this over a number of months. We involved patients. Because it wasn't obvious. It's going to be obvious when I actually give you the answer. But this was a good performing practice. It wasn't obvious why this was so high. And there were all sorts of things going on, like where we had a duty doctor and patients were being seen by, they'd come in to see their preferred GP, they couldn't see them, so they'd go and see their duty GP and come back and literally at the same time book to see their preferred GP. And there was all sorts of things going on. But following a fairly extensive review and an awful lot of pain, Mike spoke about the pain. This was very painful for clinicians to change what they were doing for years. But within 6 months, the external group, within 9 months, the external group came back and they measured it down at 6.4. So that actually is a 22% improvement in effective capacity at the practice, which is very substantive. This was at zero extra cost, other than the cost of the meetings with all the people who were employed anyway. So this is the types of improvements that I believe that you can see within healthcare systems, within practices across the divide by employing the correct techniques. Next one is an NHS health checks. Again, I don't have time to go through kind of all the ins and outs of it, but this was a service that was commissioned nationally in the NHS. The intention was to deliver cardiovascular risk assessment to eligible population within 5 years and assess 20% of the eligible population per annum. Interestingly, it was promoted as a locally enhanced services, which meant that the practices that engaged in this got remunerated based on the patient outcomes that they delivered. And again, these were all clinical outcomes, so initial assessment, putting in place a program for risk patients, etc. They weren't just given the money, they were given the money based on outcomes. So I suppose the only key piece of data from this slide is that at the time when we started it, the practice had a capacity of about 50 health checks per month. By doing some magic work, which was all about working in a multidisciplinary team with clinicians, nurses, and this was an interesting one because it affected the nurses more than anything else. And the first discussion was the nurses. They told me this is how much work they're doing, and this is how much capacity they have, which was very little, and they couldn't change anything. Well, that's not how we actually went about approaching it. We did a map of all the activities, and lo and behold, slowly but surely, we got them involved in the process. We got them to challenge some of their work practices. And again, I can only give you the result, but this is the result. Over from kind of October to July, we've gone from about 50 to about 150. There was a dip there in June due to holidays and various things. But we've trebled the capacity for NHS health checks with no additional resources whatsoever. And they're the types of improvements that I believe that can be delivered right across the health system when you get multidisciplinary teams. And the multidisciplinary teams are clinicians, managers, everybody working to their own competence. The entire process being driven by the clinicians because, i.e., what's required from the health check and the patient or the clinical pathway has to be defined by the clinicians. But all the actual process redesign and all that side of it then is done by the management and the team. Mike also spoke about the atrial fibrillation, and again, he grossly simplified what actually happened. He arrived into the practice one day and said, listen, we've commissioned atrial fibrillation. By the way, can't you do that when you're doing the flu jabs? He was very lucky not to have been at least strangled by the nurses, because it wasn't as simple as it sounded. This practice had 15,000 patients with a large percentage of those coming in for flu jabs. And they had set up over the years a system like clockwork where patients could come in on Saturdays late in the evenings, and it was all done so the patients could come in quickly, would be waiting less than a minute, in for their flu jab and gone. And it worked absolutely smoothly. Now, just to superimpose an atrial fibrillation check on top of that system was not easy. But the very interesting thing is, guess who actually did the test? It was the practice staff did the test. The practice staff were trained to take the pulse on the patients, and we set in line a process where as they came in, they got the flu jab, the trained practice staff took the pulse, and then if there were any kind of follow-up to be done, that patient was put in to see the nurse. So again, very exciting stuff. I suppose I just want to recap by saying obviously there's significant change happening within the healthcare. I think it's a very exciting opportunity, I really do. I'm not so sure I'd be waiting for ministers and people to actually make it happen. I think some of the great things that have been suggested here, and Mike spoke about people getting together informally, discussing, redefining pathways. And I think in many instances there's an awful lot we can do by actually getting on and doing it, speaking with colleagues and actually redefining some of these, demonstrating the improvement, and then maybe taking those back to the powers that be, as Minister Riley asked for this morning. He needs evidence, let's give it to him. Thank you very much.